did his MBBS from Kavya Medical College and Best Outgoing Student Award in MBBS, MD from Usmania Medical College and DM Rheumatology from NIMS. She had publication for ANCA vasculitis and Best Oral Paper presentations on Ocular G and GPA in vasculitis CMA PGH Chandigarh, Best Paper presentation on DH with infection in Sijikorn, contributor of chapters in various national textbooks, and area of interest is lupus, vasculitis and precision care in rheumatic disease. Thank you.
Thank you, sir. So without wasting the time, I'll go into my topic. I thank Manipal team for speak on the topic, approach to ANCA vasculitis involving the lung. So body of my talk will be when to suspect primary vasculitis and classification of vasculitis and nomenclature of anti-neutrophil cytoplasmic associated vasculitis and the respiratory tract involvement of GPA, MPA and EGPA and how to diagnose ANCA vasculitis and brief review of management and the survival and outcomes. So when we suspect a primary systemic vasculitis in a patient, so whenever the patient has constitutional symptoms in the form of low-grade fever for longer time, severe myalgias, arthralgias, fatigue, weight loss, and whenever there is a multi-system involvement and there is a rapidly progressive organ damage and the blood showing raised inflammatory markers, that is ESR and CRP, and CBP showing anemia with leukocytosis and thrombocytosis. So till now we have heard about the connective tissue disorders, that is CTDs, where we see leukopenia and cytopenia. So we go towards cytopenias in case of connective tissue diseases, whereas in primary vasculitis, it will move to leukocytosis and thrombocytosis. So this is a 2012 revised international consensus classification on the vasculitis, primary vasculitis. So it is classified based on the size of the vessel into large, medium and small vessel. So now we are concerned with only small vessel vasculitis. In this we have two categories. So first one is one is mediated by immune complex deposition in the vessels, that is immune complex mediated vasculitis. So the first one, and the second is post-immune mediated small vessel vasculitis, where you don't see any immune deposits in the vessel walls, that is post-immune. So in the ANCA associated vasculitis comes under the category of post-immune vasculitis. In this ANCA vasculitis, we see three different phenotypes, that is vaginous granulomatosis, now called as granulomatosis with polyangiitis, and hereby I will call it as GPA, and the other is a microscopic polyangiitis, that is MPA, and the third is the eosinophilic granulomatosis with polyangiitis, that is GPA. So it's a very rare disease, but there is increased incidence and prevalence nowadays with the availability of better diagnostic tools and improved management and survival of these patients with the advent of novel agents. So, but still there is a delay in diagnosis of these rare diseases because they have varied non-specific symptoms. So, what's the two main pathological features of ANCA vasculitis? See, we see mainly two patterns. First one is the vasculitis, that is there is necrotizing inflammation of the small vessels, arterioles, capillaries and venules, where we see inflammation in the vessel walls. And the second pattern is, this is vascular manifestation, and the second is a granulomatous manifestation, which is extravascular, where we see necrotizing granulomas in the tissues. So in GPA, we see vasculitis as well as granulomatous manifestation. Whereas in MPA, we see only vasculitis, there are no extravascular granulomas. Whereas in EGPA, we see both vasculitis as well as granulomas. But the difference between granulomas in GPA and EGPA is, the granulomas are predominated by neutrophils in GPA, whereas in EGPA, the granulomatous inflammation is predominated by eosinophils. So whenever you see a biopsy to diagnose ANCA vasculitis, either we should have vasculitis or granulomas. So these three different types of ANCA vasculitis have different predilection for the involvement of various organs. So for the first is the GPA, where we see predominant upper respiratory tract involvement, lower respiratory tract involvement and renal involvement in the form of glomerulonephritis. In the upper respiratory involvement, the nasal symptoms can be in the form of nasal discharge, crusting, ulcers and leading to hyposmia, and finally there will be a saddle nose deformity or septal perforations. The other is the ear involvement in the form of serous otitis media or mastoiditis or otitis externa, finally leading to either conductive or sensory neural hearing loss. The other is the oral manifestations where we see palatal ulcers leading to erosions and bone damage, and strawberry gingivitis. These are the important symptoms we should ask in any patient we suspect ANCA vasculitis, because these are usually the neglected features and they won't even think whether they have vasculitis. So the next is the MPA, where we see predominantly pulmonary renal involvement, pulmonary renal syndrome, where the patient presents with diffuse alveolar hemorrhage in the lungs along with glomerulonephritis. And usually the upper respiratory involvement is less in MPA, and it is predominant neuropathy. And the third is EGPA, where we see the features evolving over 3 different phases. The first is the allergic phase, where only the upper and lower respiratory tract involvement is seen. And the second is the eosinophilic stage, where the symptoms are predominated by eosinophils involving the gastrointestinal tract, cardiac system, or the lungs. And the third is the vasculitic stage, where we see glomerulonephritis or neuropathy. So these are the 3 different types of ANCA vasculitis with different predilection for involvement of the organs. So now we are concerned with only the respiratory tract involvement in ANCA vasculitis. First I will be covering the GPA and MPA. So the incidence is around 62 to 90% with varied symptoms, and the pattern can be in the form of 4 different types of presentations. The first is a tracheobronchial inflammation. The second is a pulmonary capillaritis, otherwise called diffuse alveolar hemorrhage, which is more commonly seen in GPA and MPA than EGPA. And the third is a necrotizing granulomatous inflammation. There is no vasculitis, only granulomas. And the fourth is the evolving concept, that is interstitial lung disease. So these are the 4 main patterns of respiratory involvement in ANCA vasculitis. So first manifestation, that is tracheobronchial inflammation. Any site can be involved, but the most common site being the subglottic region, and it can occur in any stage of the disease. And they can present with either simple mucosal abnormalities like mucosal ulcerations, edema, cough with secretions, or sometimes they can form a pseudotumor leading to obstruction of the bronchus. And the third common presentation is the subglottic stenosis, SGS. And the fourth is the tracheobronchial inflammation with stenosis. See, this subglottic stenosis is usually missed case. It is seen in up to 10 to 20% of the cases. Patients usually present with slowly progressive shortness of breath, and usually the diagnosis is missed until the patient presents with stridor and severe wheeze. So it occurs in isolated forms, and no other manifestation of GPA can be seen. And the other is a tracheobronchial inflammation with stenosis, that is second one, where it is often associated with systemic disease. So if it is untreated, it can lead to scarring of the bronchus, and sometimes it may require lobectomy or pneumonectomy. So here I would like to discuss a small case. So here is a young female where she first presented to me with conductive hearing loss and vasculitic ulcers in her lower limbs. She was treated with pulse steroids and cyclophosphamide. She was nicely cured and all her ulcers are healed, and she was put on azathioprine, doing well, extremely well for 1 year. Then again she presented with a slowly progressive shortness of breath with mild low-grade fevers. X-ray was completely normal. CT chest was done, which was showing only minimal GGOs in the upper lobe. Suspected infection, done all the cultures but negative. So just increased a little bit of steroids and sent her. But after 2 months, she presented with worsening of dyspnea. She was unable to move in and around the house. So when she came again, we could hear a stridor from her voice. So again the repeat CT was done, but lungs are extremely normal. We could see even the trachea was not showing any thickening. So we requested the municipal pulmonology team to do a diagnostic bronchoscopy. Here it was showing nicely the subglottic stenosis. So this was identified with diagnostic bronch, and later she was went for electrocarotid cuts with steroid instillation, and rigid bronchoscopic dilatation of the bronchus was done. And she was started on rituximab and steroids, and it was down the lane 8 months. She was doing extremely well without any shortness of the breath. So this is a second type of symptom, that is necrotizing granulomatous inflammation. See, here we can see different types of nodules. So these are the different size of nodules we can see, which are scattered throughout the lungs. It can be single or multiple, unilateral or bilateral. There is no predilection for any zones. we can see the nodules varying in size from few mm to more than 10 centimeters in size. And these can have a halo sign, that is central opacity with surrounding ground glass opacities. So till now we had heard that the halo sign is typical of infections. We rule out generally all the infections, but I would like to add one more differential for the halo sign in CT, that is ANCA vasculitis. So we can see the halo sign, and usually nodules of more than 2 centimeters in size can cavitate even, leading to central necrosis and cavitations. We can see the third one. And the fourth is we can see airspace opacities. When they are mild, it is ground glass opacities. When they are dense, they form a consolidations, and there is bronchial wall thickening, we can see, and they can be seen tracheal stenosis as well as pleural effusions. So these are the various granulomatous inflammation, types of granulomatous inflammation we can see in a case of ANCA vasculitis. So if you take a biopsy, we can see granulomatous inflammation from such lesions. And what's their prognosis? Usually 50% resolve completely without leaving any sequelae, but usually cavities more than 5 centimeters, usually they heal with some scarring, and 10% remain unchanged. And usually the main differentials for these nodules are infections, neoplasms, and organizing pneumonia. So here is a short case of 40-year-old female. She presented with fever, cough, and shortness of breath, and her X-ray was showing all these nodules diffusely distributed in both the lungs. So she approached a pulmonologist, bronchoscopy was done, all the cultures are sterile, and biopsy was showing no features of malignancy, and they could find a granulomatous inflammation in the biopsy. So, but we take a careful history. She had hearing loss for the past 6 months. And when we clinically examined, she had this saddleness deformity, which is there since for the past 1 to 2 years, which she was following up at ENT. So her anti-PR3 antibodies was done, which was positive, and thus she was diagnosed as having GPA. Coming to the third manifestation, that is pulmonary capillaritis, which is a vasculitic manifestation of ANCA. So usually in the mild cases, usually we see diffusely distributed infiltrates in the lungs. When they are small, it is called, they can present as pulmonary infiltrates or wedge-shaped pulmonary pleural region. And if it is diffuse, it causes alveolar hemorrhage. And if we take a biopsy from such lesions, we usually see vasculitis, not granulomas. So this is diffuse alveolar hemorrhage. It is most commonly seen in MPA and GPA, and it is very rare in EGPA. And usually patients presents with cough, shortness of breath, and hypoxia. And the main is hemoptysis is present in only 50% of cases of diffuse alveolar hemorrhage. So don't think if the patient doesn't have hemoptysis, DAH is not there. And CT chest, it was showing diffuse ground glass opacities. Here we can see diffuse ground glass opacities, usually in the perihilar region and mid and lower zones, and sparing the subpleural region. And the labs, we can see there is 100% there is anemia with a drop in hematocrit. So this is more sensitive than hemoptysis. And diagnostic bronchoscopy, which shows increasing RBC count with serial ball samples. And if the DAH is more than 48 years old, we can see more than 20% siderophages in the ball samples, and this is diagnostic of diffuse alveolar hemorrhage. So it is a potentially life-threatening condition. Approximately 2/3 requires mechanical ventilation and dialysis. And if it is mild, it can be subclinical also. And the factors predicting respiratory failure are presentation with hypoxia and high CRP at the time of presentation, and high neutrophils in the ball sample. And factors associated with mortality are presentation elderly people with presenting with hypoxia and requiring mechanical ventilation and dialysis. So coming to the fourth pattern, that is interstitial lung disease in ANCA vasculitis. This is a growing, it has growing evidence nowadays. So usually we think of connective tissue disorders when associated with ILD, but ANCA also has a role, and it is usually seen in microscopic polyangiitis, and anti-MPO antibodies are seen in up to 71% of the cases compared to anti-PR3 antibodies. And UAP pattern predominates in them, and usually in MPA, the ILD precedes vasculitis, whereas in GPA, the ILD occurs after vasculitis, and it usually carries a bad prognosis. So now, previously also in idiopathic pulmonary fibrosis, no guidelines say that we have to test for ANCA in a case of IPF, but the literature shows us there is 4 to 36% of anti-MPO antibody positivity in a case of idiopathic pulmonary fibrosis, and so we do recommend ANCA testing in any case of interstitial pneumonias or patients with having idiopathic pulmonary fibrosis. And at the initial stages, 10% of ANCA negative IPF patient can seroconvert to over 1 year. So this is the respiratory tract involvement of GPA and MPA. The pattern is a little bit different in EGPA because it evolves over 3 phases. The first phase is the prodromal phase, where we see only simple allergic symptoms, that is rhinitis, sinusitis and rhinosinusitis. In the lower airway, they present with asthma, but the clinical feature is it is usually an adult onset asthma, not a childhood onset, and there are no seasonal exacerbations unlike the asthma seen in general population. And if there is any childhood, there will be worsening of the childhood onset asthma. So these are simply the allergic manifestations which are the prodrome for the EGPA for over many years. They can stay in that phase for many years. And the second is the eosinophilic stage, where there is blood eosinophilia and the infiltration of these eosinophils into the tissues, causing tissue eosinophilia and the symptoms like nasal polyps and migratory infiltrates in the lungs and GGOs and eosinophilic pleural effusions, where we see predominant eosinophils in the pleural fluid samples. And the third is the vasculitic phase, where we see small vessel vasculitis, that is presentation of diffuse alveolar hemorrhage or GGOs, but it's a very rare feature in EGPA. So how do we diagnose ANCA vasculitis? First is the typical clinical features. We have to ask all the clinical features regarding to the upper respiratory involvement, lower respiratory, hearing loss, any skin rashes, any neuropathy. So ask all the questions in the history because they have any organ involvement. And the second is the imaging, X-rays followed by CT scanning, but CT scanning is more sensitive than the X-ray. And the third is the ANCA serology. ANCA is done usually by 2 types. One is the indirect immunofluorescence method and the other is the newer immunoassays, that is ELISA based. So now the general guidelines recommend doing ANCA by newer immunoassays rather than immunofluorescence. So here in immunofluorescence we see 2 different patterns. That is the cytoplasmic staining, where entire cytoplasm is stained, that is called C-ANCA pattern, and only the P-ANCA, where we see staining only in the perinuclear region, that is popcorn type appearance, that is called P-ANCA pattern. So C-ANCA is nothing but anti-PR3 antibodies and P-ANCA is nothing but anti-MPO antibodies. So now we generally classify them as anti-PR3 positive or anti-MPO antibodies because they have prognostic implications. So anti-PR3 antibodies are more common in GPA, 75%. Anti-MPO are more common in microscopic polyangiitis, 65%. And around 5 to 10% are ANCA negative in GPA and MPA. In such cases, we diagnose them based on their biopsies. And in EGPA, the ANCAs are usually negative in 65% of the cases because they have predominant allergic symptoms and eosinophilic symptoms rather than vasculitic symptoms. So the other diagnostic clues in the bladder, I have told you, there will be leukocytosis and thrombocytosis rather than leukopenia and thrombocytopenia. And in the renal, look for any active urinary sediment. And in the biopsy, we can see either vasculitic features or a granulomatous inflammation. And now with the availability of bronchoscopy, we could get more samples from the lung tissue, diagnostic, as well as to rule out all the infections, and also therapeutic, like the case we saw in subglottic stenosis. Coming to the management briefly, it includes 2 phases, induction phase and the maintenance phase. Induction phase, only I am pertaining to the lung tissue. We have to classify the symptoms as organ threatening or non-organ threatening. In organ threatening, we have all the cavitatory lung lesions, diffuse alveolar hemorrhage and subglottic stenosis, where we start with 1 mg per kg steroids or if necessary pulse steroids, and followed by we prefer rituximab over cyclophosphamide in induction regimen of organ threatening features. Rituximab is preferred nowadays for many reasons, like patient who wants to conserve their fertility, who wants to reduce the cyclophosphamide usage to prevent bladder cancers, and also the rate of infections with rituximab induction are lower compared to cyclophosphamide induction therapies. If the patient is having non-organ threatening features like non-cavitating lung lesions or just simple pulmonary infiltrates without any hemoptysis, or airway lesions not damaging the bone or cartilage. So not damaging is important. So those symptoms comes under non-organ threatening features. In such cases, we can go with 0.5 mg per kg steroids, and we prefer rituximab over azathioprine or methotrexate for induction in non-organ threatening features of ANCA. So once the patient, this is the induction regimen, and taper the steroids slowly over the 4 to 5 months. And once a patient goes into remission, the problem with ANCA vasculitis is they usually tend to relapse. So to prevent the relapses, we have to give a maintenance therapy that is approximately for 2 years, and in the remission, we prefer rituximab over azathioprine or methotrexate. So for at least 48 months, that is 2 years. And the decision to continue immunosuppression beyond 2 years in a case of ANCA vasculitis is decision making is decided based on the patient factors for his relapse risk. So the relapse rate is approximately 38 to 54% in the case of ANCA vasculitis, and the risk factors being elderly people with upper respiratory, lower respiratory, cardiac, or patients with high GFR. Basically, patients who land up in end-stage renal disease at the time of presentation, they won't have risk of relapses. So patients who have high GFR have more chances of relapse. And PR3 antibodies are at more risk of relapse compared to anti-MPO antibodies. That's why we are moving more towards immuno-based assays to diagnose ANCA, that is anti-PR3 or anti-MPO rather than ANCA-IF. So, and the low dose of cyclophosphamide used and shorter duration of immunotherapy which we give in induction treatment, that is also risk for patient having relapse. So, the main cause of mortality in ANCA vasculitis in the first year is two main factors, that is infections and active vasculitis, and infections contribute up to 48%. And the main reason for having infections is high glucocorticoid use. Other than the patient comorbidities, we are the people who are going to introduce infections in all these people with our immunosuppressant drugs. So that's the main culprit is higher glucocorticoid use rather than cyclophosphamide and rituximab. So to decrease the usage of glucocorticoid in the induction regimen, basically a recent study was done, that is PEXIVA study, where they have used two different types of glucocorticoid regimen. There is a standard regimen and the other is a low dose regimen. In the low dose regimen, we usually bring down the steroids to 20 milligrams at the end of 1 month and to 5 milligrams at the end of 4 months. So with this regimen, there is usually a 40% reduction in the glucocorticoid usage, and with this 40% reduction, they could identify there is a 6% reduction in the risk of serious infections in the first year. So next is the controversial role is regarding the role of plasmapheresis in diffuse alveolar hemorrhage. So the impact of this plasmapheresis and DAH mortality is still controversial and it needs more further studies. The previous trials, that is MIPEX and PEXIVAS trials, there was no survival benefit of plasmapheresis in patients with AAV with diffuse alveolar hemorrhage. And the main factor, the main reason or driver for initiating plasmapheresis is underlying renal dysfunction in patients with ANCA vasculitis. And PLEX usually have is considered if the patient's serum creatinine is more than 3.3 but less than 5.5. In such cases, patients, there is usually a decrease in the chance of end-stage renal failure at the end of the 1 year, but there was no survival benefit with plasmapheresis. The reason being, the patient is already severe, should have landed in severe stage, and the second is increased rate of infections with plasmapheresis because this is an invasive procedure, and the main cause of mortality in ANCA vasculitis in the first year is infections. So balance the against the risk of infection and cost and risk of the procedure of plasmapheresis while initiating the therapy. So there is 2.6 times higher mortality in ANCA vasculitis, and now there is a decline in the mortality because there is a reduced time to the diagnosis with the advent of newer techniques and lesser cumulative dose of cyclophosphamide. We are moving more towards rituximab than cyclophosphamide based regimens now. And the survival rate at the end of 1 year is 88% and at the end of 5 years it is 78%. And the main causes of death in the first year is infections and vasculitis, and after first year it is mainly because of the cardiovascular events, malignancy and infections. So how to overcome this and improve the survival? So to prevent the risk of infections, usually we vaccinate all the patients who are going to have high dose immunosuppression and use lower glucocorticoid dose regimens as reported in PEXIVA's protocol, and cotrimoxazole patients for every patient who are more than 15 milligrams of steroids and whenever they are on cyclophosphamide and rituximab based protocols, and control of other associated comorbidities, and IVIG replacement therapy in patients who are on prolonged rituximab therapy where their immunoglobulin levels are very low. And to decrease the risk of pulmonary fibrosis, early diagnosis is important, and initiating treatment with a combined immunomodulating agents, that is glucocorticoids with cyclo or rituximab, not glucocorticoids alone. And the third is the cardiovascular risk, where we have to control the vascular inflammation appropriately and screen and management of severe risk factors. And the fourth one is the malignancy, as we are nowadays using lower cumulative doses of cyclophosphamide. That is, previously they have given oral cyclophosphamide where there is higher cumulative dose, but now we are moving to IV pulse therapy cyclophosphamide where the cumulative dose has reduced, and still we are moving more towards the rituximab to avoid the cyclophosphamide toxicity. So my take home message is early diagnosis is important to prevent irreversible organ damage, and early diagnosis is now possible with these endoscopic biopsies and newer immunoassays, and the intensity and duration of immunosuppressive therapy should be balanced against the risk of infection and malignancy, and follow low glucocorticoid regimens and effective treatment with combination drugs rather than glucocorticoids alone. Thank you.
Due to lack of time, we will have